Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome dear students in my surgery lecture number 74, that is the blood transfusion and blood substitutes. In this lecture we will cover the blood transfusion, the indication for the blood transfusion, collection of the blood for blood transfusion, blood storage, types of the blood transfusion, blood groups, complication of the blood transfusions, that is the reactions of the blood transfusions, blood substitutes like plasma, FFP, fresh frozen plasma, fibrinogens, and synthetically prepared blood substitutes like dextran, gelatinine and hydroxyethyl starch. All points are covered in this lecture. Now first start with me the blood transfusion. The indication, the commonest indication of the blood transfusion is acute haemorrhage to be the external or internal. Next indication is it is indicated during the certain major operations where a good amount of the blood loss is inevitable, that is the radical mastectomy, abdomino-perineal resection, etc. Third indication in the blood transfusion is in case of the deep burns, blood transfusion is indicated besides the initial fluids and plasma administration, as there is a considerable haemolysis and destruction of the RBCs. Fourth indication is of the blood transfusion is the preoperatively blood transfusion is required when the patient is already anemic and there is no adequate time for iron replacement therapy before operation. Here is a good picture showing the replacement of the transfusion. Now the fifth indication of the blood transfusion is due to the excessive bleeding during operation. Next indication is when the hemoglobin level is below 10 gram per 100 ml, blood transfusion is often indicated to treat the anemia. It must be remembered that in chronic anemia it is better to transfuse packed cells rather than the whole blood to reduce the more burden to the already burdened heart due to the hypervolaemia. Next indication is the malnutrition, hypoproteinemia. Blood transfusion is indicated before any type of surgery. Next indication is the certain coagulation disorders like hemophilia, Christmas disease, as we see in the last lecture, thrombocytopenic purpura, etc. Blood transfusions or blood fraction transfusions are required. During chemotherapy of the malignant diseases, blood transfusion is often indicated. Now, the next point of this lecture is the collection of the blood for the blood transfusion. Before collecting the blood, this is the most important. Before collecting the blood from an individual donor, one has to make sure that the donor is not suffering from any diseases which may be transmitted through the blood. The donor is not suffering from must not be suffering from hepatitis A, B, C, D, E or AIDS, which is transmitted by the HIV first and second viruses. About 410 ml of the blood is taken in a single bag at a single sitting. Two types of the anticoagulant solutions are usually used to mix with the donor blood. CPD solution contains trisodium citrate, dihydrate, citric acid, monohydrate, sodium dihydrogen phosphate, monohydrate and dextrose mixed with the water to make the solution. With the above mentioned solution, adenosine is added, that is the CPDA1, to increase the storage life of the blood. Average storage life of the blood is the 120 days. Now the blood storage. All bloods that are collected from the donors are stored in the blood bank in special refrigerator at the controlled temperature of 4 degrees centigrade, ranging from the 6 degrees centigrade to 2 degrees centigrade. If blood is allowed to come in contact with higher temperature, there is a danger of the transmitting infection through the blood. During storage of the blood, the red blood cells or erythrocytes, which constitute the major components, lose their ability to release the oxygen to the tissues of recipient within the 7 days. So when the patient requires massive transfusion, it is advisable to use the least 1 or 2 units of the blood which are less than 7 days old. White blood cells or WBC are rapidly destroyed in the stored blood. Platelets are also destroyed considerably at 4 degrees centigrade, but a few are still functionally useful after 24 hours. Clotting factor, that is the factor 5 and factor 8, and the platelets are also destroyed quickly. Shelf life of the stored blood in CPD solution is about 3 weeks. When blood is stored in CPDA, first the solution, the storage life is increased to 3 weeks. Now the types of the blood transfusions. Type of the whole blood transfusion may be used. First is the typical stored CPD blood from the blood bank is mostly commonly used nowadays. Second is the warm blood. During cardiopulmonary operation, the blood may be warmed by passing the stored blood through a blood warming unit to reduce the risk of the cardiac arrest, which may be caused by the transfusion of the large volume of cold blood direct from the blood bank. Third type of the blood transfusion is the filter blood, sometimes used by the filtering blood through a membrane with 4 nanometer pores to filter off platelet aggregates and leukocytes in the stored blood. Fourth type of the blood transfusion is the auto infusion. That is an old method of restoring of the patient's blood volume by transfusing his or her own blood who is excessively losing blood by injuries such as ruptured spleen or ruptured liver or in the ruptured ectopic gestation. The blood is collected from the peritoneal cavity and put into the sterile container. The blood is now filtered through a few layers of the sterile gauze into the container which already contain anticoagulant, that is the CBD solution. This blood is now immediately transfused into the patient. This method is particularly used when the stored blood is not available. Next type of the blood transfusion is the exchange or replacement transfusion, is indicated in the newborn infant suffering from the erythroblastosis fetalis. Now the packed red cells. This is specially transfused to the patient with chronic anemia in elderly individuals, in children and in those patients whose cardiac reserve is low and may suffer from the cardiac failure if whole blood is transfused. If the whole blood is centrifused at 2000 to 2500 gram for 15 to 20 minutes, or if the stored blood is allowed to stay ideal so that the supernatant plasma is taken off and the blood sediments is used for packed cells. Other fractions of blood, that is the plasma platelet, rich plasma etc. are also transfused in various conditions. Amount of blood transfusion, it should be kept in mind that approximately 70% of the total amount of blood loss should be replaced by the transfusion of blood. 500 ml of CPD stored blood will generally raise the hemoglobin by 10%. Now the blood groups and compatibility. Blood groups, the red cells contain anti-agglutinins named A and B, and the serum contains agglutinins named anti-A and anti-B. For transfusion, the red cells of the donor are matched against the serum of the recipients, as agglutinins present in the recipients are in high titer. According to the presence or absence of the two agglutin genes A and B, and there are 4 blood groups. Group A is one whose red cells contains A agglutin genes and the serum contains anti-B agglutinins. Group B is one whose red cells contains B agglutinin genes and the serum contains anti-A agglutinin. Group AB is one whose agglutinins red cells contain both A and B agglutinin genes and the serum contains neither anti-A or nor anti-B agglutinins. Group O is one whose red cells contains neither A or nor B agglutinin genes and the serum contains both anti-A and anti-B agglutinins. The person with group AB can receive blood from any group, that is the universal recipients. The person with group O blood can give blood to anybody as it has got no agglutinogens in the red cells, that is the universal donor. So, in emergency, one can use group O blood if the time does not permit to do proper grouping and cross matching or to wait for the availability of the proper cross match blood. Now there is another factor known as the rhesus RH factor, which is very important to be considered during the cross matching. RH factor, this is an antigen found in the red cells. Human beings can be divided into RH positive and RH negative groups. Accordingly, whether the red cells contain RH factor or not, obviously with RH positive blood group do not possess RH antibody in the serum. When RH positive cells are injected into the RH negative person, the antibody RH develops. The first transfusion may escape to produce any problem, but further transfusion will definitely produce serious reactions. A similar condition happens when a RH negative woman carries RH positive fetus. The red cells of the fetus, when come in contact with the mother serum, will form anti-RH. The anti-RH will pass into the fetal circulation and destroy the red cells of the fetus, producing hemolytic reaction. Approximately 85% of the population are RH positive and 15% of the population are RH negative. Now, incompatibility. In incompatibility, blood has been transfused agglutinations and then hemolysis of transfused RBC occurs. If hemolysis is severe, it may cause acute renal tubular necrosis, renal failure and death of the individuals. So, it is extremely essential that the compatibility of the donor's blood is checked. This is done by the transfusion of the blood of the same group as the recipient should be given. RH compatibility should also be checked, that the means RH status of the transfused blood should be similar to the RH status of the recipient. And the next entity in the incompatibility is the direct cross matching of the donor's red cells against the recipient's serum should be performed before transfusion. Now the complications of the blood transfusions. These transfusions are in 2 groups. First is the transfusion reactions and second is the transmission of the disease. First is that is the transfusion reactions. First, the following are the various transfusion reactions which may be seen as a complication of the blood transfusion. First is the incompatibility, second is the Pyrexial reaction, then allergic reactions, sensitization of the leukocytes and platelets, bacterial infections. All these are the transfusion reactions. First, incompatibility. There are three causes of the incompatibility. First is the incompatible transfusion. Second is the transfusion of blood which is already hemolyzed by heating or overfreezing or shaking. Third is the transfusion of the blood after expiry date. From the above causes, it is clear that the incompatibility is mainly due to the human error, negligence in looking at the label of the blood bottle, and imperfect grouping and cross matching. So, always remember that the blood group and cross matching and the blood bottle label should be matched with the patient's blood group and rhesus factor. The clinical features of the incompatibility. Once the incompatible blood has been transfused, the patient first develops rigors and fevers, headache, nausea and vomiting, pain in the loins, tingling sensation in the extremities. Pain in the loin is a very characteristic feature and it indicates blockage of the renal tubules, which means grave consequences. Pain in the loin may be preceded by the feeling of the tightness in the chest and dyspnea. Urine output is gradually diminished and hemoglobinuria occurs within 2 to 3 hours. Appearance of the jaundice is a definite sign of the incompatible transfusion and is usually appears within 24 to 36 hours. Ultimately, renal failure sets in due to the blockage of the renal tubules with hematine pigments. Administration of the fluids intravenously should be started instead of the blood. Hematine pigments tend to be precipitated in acid medium, so alkalization of the blood should be done with 10 ml of isotonic solution of the sodium lactate, and simultaneously 10 ml of the saturated solution of the sodium bicarbonate are injected. Intravenously, furosemide 80 mg to 120 mg intravenously is given to provoke the diuresis, may be repeated if the urine output is not increased up to 30 ml per hour. There is a high chances of the renal failure. Now the treatment in the incompatibility. If there is an incompatibility, the transfusion should be stopped immediately. Fresh specimen of the venous blood and urine from the patient are sent to the laboratory for checking along with the rejected bottle of the blood. Administration of the fluid intravenously should be started instead of the blood. Hematine pigments tend to be precipitated in the acid medium, so alkalization of the blood should be done with 10 ml of the isotonic solution of sodium lactate and simultaneously 10 ml of the saturated solutions of the sodium bicarbonate are injected intravenously. Furosemide 80 to 120 mg intravenously is given to the provoke diuresis. This may be repeated if urine output is not increased up to 30 ml per hour. Antihistamine and hydrocortisone may be prescribed. Hemodialysis with artificial kidney may be used in extreme cases. Now the second complication of the blood transfusion is the Pyrexial reaction. Complication of the blood transfusion. Sometimes the blood transfusion is accompanied by the pyrexia, chills, rigors, restlessness, headache and increased pulse rate, nausea and vomiting. The causes of the such Pyrexial reaction are as follows: improperly sterilized transfusion sets, presence of pyrogens in the donor apparatus, transfusion of the infected blood, presence of the sulfur compounds in the rubber tubing. This is not used nowadays due to the availability of the plastic disposable sets. Very rapid transfusion of the blood. Treatment: the transfusion should be stopped immediately for the temporary time. The patient is covered with blanket. Antibiotic and antihistaminic drugs are injected intravenously. Transfusion is again started with a fresh plastic disposable set at the slow rate. Now the third complication of the blood transfusion is the allergic reaction. Mild tachycardia, urticarial rash, fever and dyspnea is the symptoms in these allergic reactions of the blood transfusion, complication in the blood transfusion. In acute cases, there may be circulatory collapse, which is known as the acute anaphylactic shock. The cause is the allergic reaction to plasma product in the donor's blood. Now the treatment of the allergic reactions in the complication of the blood transfusion are: the transfusion is immediately stopped. Antihistaminic drugs, that is the chlorpheniramine 10 mg or diphenhydrazine 25 mg should be administered. Sometimes the hydrocortisone and calcium may be administered in the acute anaphylactic reactions. Fourth complication of the blood transfusion reaction is the sensitization to the leukocytes and the platelets. This is occasionally seen where the many blood transfusions have been given in the recent post. The patient develops antibodies against the white cells and platelets of the donated blood. This causes reactions. Prevention: such unusual reactions can be avoided by the giving packed cells, red cells, whenever many blood transfusions are required. Treatment: antibiotic, antihistaminic and steroid may be given to combat the reactions in the treatment of the sensitization up to the leukocytes. Transmission of disease: most common serious complication directly attributable to transfusion is the transfusion of the disease. Now, the second type of the complication of the blood transfusion is the transmission of the disease. The most common serious complication directly attributable to transfusion is the transmission of the disease. First is the serum hepatitis. About 1% of the cases passes undetected. The symptoms and signs of the serum hepatitis is usually revealed within 3 months after the transfusion. Second is the acquired immune deficiency syndrome, that is the called AIDS. As you know all about the AIDS, so I am not describing and giving detail in this regard. Now next is the bacterial infection. This is not a common and occurs due to the faulty storage technique. The donor's blood, when left in a warm room for some hours before transfusion, bacterial infections to the recipient may occur. In fact, in this warm room, temperature proliferation of any bacteria may take place. Such bacterial infection is revealed by septicemia in the recipient. Now the third group is the reaction caused by the massive transfusion. Among of that, the first is the acid-base imbalance is reasonably expected in the massive transfusion. Extensive transfusion usually results in significant metabolic alkalosis. This is because most of the citrate in the anticoagulant solution is present as sodium citrate, which becomes sodium bicarbonate as the citrate is consumed. This alkaline nature of the blood may help the patient who is already acidotic. Second is the hyperkalemic. This is due to the shift of the potassium out of the red cells due to the low temperature of the storage, but after transfusion the transfused red cells take back as much potassium as they had released during the storage. So at the end there should not be hyperkalemia at the end of the transfusion. All studies show that the patient at the end of the massive transfusion and hypokalemic, this is probably due to the alkalosis induced by the massive transfusions. This should be remembered. And third, in the reaction caused by the massive transfusion is the citrate toxicity, is mainly a theoretical problems rather than practical. Its mainly effect is to consume the ionized calcium from the patient's body, but the body mobilizes calcium rapidly from the skeletal stores, so supplements calcium is not required. And fourth cause in the reaction caused by the massive transfusion is the hypothermia. If the patient is in the operation theatre, he is paralyzed and unable to shiver. Consequently, these patients almost always experience a drop in the body temperature at least 3 to 4 degrees. Next caused by the massive transfusion is the failure of the coagulation. Probably the most important danger of the massive transfusion is the failure of the natural process of the coagulation. This is the mainly caused by two factors. One is the dilution of the platelets and various clotting factors due to the transfusion of large volume of stored blood. As stored blood has low content of the platelets, fibrinogens and various coagulant factors, factor 5 and 5-8, etc. And second cause for the failure of the coagulation is the disseminated international coagulation, that is the DIC. Has been the complication of massive transfusion. This of course follows obvious and incompatible blood transfusion, but this may be noticed in certain cases of the massive blood transfusions. Now the treatment of the DIC, that is the disseminated intravascular coagulation failure, is mainly treated by the transfusion with fresh frozen plasma, platelet concentration and cryptoprecipitate. If the DIC is considered to be the cause of the heparin may be used. Now the next is the complication of the over-transfusion. All these are the complications of the blood transfusion. This is the complication of the over-transfusion. These cases should be transfused with packed cells rather than the whole blood. Congestion cardiac failure is particularly seen if whole blood transfusion is given to chronic anemic patients and elderly individuals. In case of the chronic anemia, packed red cells should be transfused and diuretics should be prescribed. Transfusion should be given slowly at the rate of the 1 unit in 4 to 6 hours. Patiently. Patient over 60 years of age should also be given packed red cells with diuretics. They should not be transfused more than 300 ml at a time. Now the next point is complication of general intravenous fluid administration. A few complications are common to any intravenous infusion. These complications are common to any intravenous infusion. These complications may also occur after blood transfusion. These are thrombophlebitis, air embolism, etc. Considering the complications and dangers of the blood transfusion, it should be concluded by saying the best amount of the blood to give is the least amount that is needed. Means you have to only transfuse the blood which is the least amount, which should be needed in the least amount. Now the next point of this lecture is the blood substitutes. Where the blood is not available, then these blood substitutes should be used. Where blood substitutes may be used to replenish the blood loss, but the blood is the best replacement for the blood loss due to its oxygenation carrying ability, which is missing in the blood substitutes. Remember this. Normal arterial oxygen content is 20 ml per deciliter and normal venous oxygen content the 15 ml per deciliter. This oxygen content is dependent on hemoglobin. concentration, and if HB concentration goes down by 50%, arterial oxygen content will also be reduced to 50%. The blood substitutes can be basically divided into two groups. One A is the plasma and its derivatives, and second is the synthetically prepared various solutions. In the group A, plasma and its derivatives like the plasma, fresh frozen plasma, platelet-rich plasma, platelet concentration, fibrinogens, albumin, and cryoprecipitates. And in the group second, synthetically prepared various solutions are dextran, low molecular weight dextran, gelatin, hydroxyethyl starch, that is called as HES, fluorocarbons, etc. Now, first we see the plasma and its derivatives. Plasma. If the whole blood is kept, sometimes a sediment will form at the bottom of the container. The upper clear portion in the plasma and the blood sediments is the packed red cells. The whole blood is centrifuged at the rate of the 2000 to 2500 gram or rotation for 15 to 20 minutes. The whole blood will be divided into two groups, plasma and packed red cells. The plasma can thus be prepared separated from the blood. Now the next plasma and its derivatives are the fresh frozen plasma. Plasma removed from the fresh blood, which is obtained within the 4 hours, is rapidly frozen by the immersing solid carbon dioxide and the ethyl alcohol mixture. Such plasma is stored at -20 degrees centigrade. This process preserves all the coagulation factors, particularly factor 5 and factor 8, which are the important in the coagulation. Such plasma is very useful in the treatment of the coagulation deficiencies in liver diseases, in hemophilia factor 8 deficiency, in Christmas disease, that is the factor 9 deficiency, and in defibrillation cases. It is also useful in the cases of the vitamin K deficiency. Next plasma and its derivatives is the platelet-rich plasma, which is suitable for transfusion to patients who are suffering from the thrombocytopenic purpura. Platelet concentrate. Platelet concentrate is prepared from the platelet-rich plasma by centrifugation at the rate of the 1500 gram for 20 minutes. The platelet remains active in the vitro for 48 hours. If the platelet concentrate is stored frozen, its effectiveness may be extended to the many months of the storage. Both platelet-rich plasma and platelet concentrates are used in the cases suffering from the thrombocytopenic purpura. Next plasma and its derivative is the fibrinogen. It is the prepared by the organic liquid fractionations of plasma. It is stored in the dried form, and before using it is made soluble with the distilled water. Such solution is required in cases of the severe depletion of the fibrinogens, that is the congenital afibrinogenemia, and is disseminated intravascular coagulation, that is the DIC, disseminated intravascular coagulation. Next derivative of the plasma is the albumin. Albumin is prepared by the repeated fractionation of the plasma by organic liquids, then followed by the heat treatment. It may be stored for the several months in the liquid form at 4 degrees centigrade. The main advantage of this is that it is free from the danger of the transmission of the serum hepatitis. In patients with severe albumin loss, that is the following severe burn and in nephrotic syndrome, main disadvantage of it is that it is very costly. Next derivative of the plasma is the cryptoprecipitate. The glutinous precipitate is known as the cryoprecipitate. It is usually stored at -40 degrees centigrade. It is very rich source of the factor 8, so it is best treatment of the patient in the hemophilia, that is the factor which is from the factor 8 deficiency. Now the group second of blood substitutes is the synthetically prepared various solutions, that is first is the dextran. It is polysaccharide polymer with varying molecular weight. The bacterium Leuconostoc mesenterocytes produces the polysaccharides compound to which a yeast extraction is added. The molecular weight of such dextran may vary from 40,000 to 1,50,000. It also interferes with the platelet functions so that it may induce abnormal bleeding. Solutions should not be used more than 1000 ml. It also interferes with blood grouping and cross matching. So, blood sample for grouping and cross matching should be drawn before introducing this solution. Two types of the dextran are usually used. First is the low molecular weight dextran, and second is the high molecular weight dextran. Low molecular weight dextran molecular weight is 40,000. This is known as the Riomacrodex or dextran 40. Dextrans are usually to restore plasma volume. And second is the high molecular weight dextran, molecular weight is 70,000. This is also known as a dextran 70. Its main use to restore the plasma volume for a longer time, as the large molecules are not excreted by the kidneys and are retained in the circulation for longer period. Second synthetic prepared various solution is the gelatin. Gelatin solutions are among the first used as a blood substitute. This is less effective than the dextran as plasma volume expander. Third synthetic solution is the hydroxyethyl starches, that is the HES, it is made by the treating the starch with sodium hydroxide, ethylene oxide. Fourth synthetic solution is the fluorocarbons. These are hydrocarbons in which the hydrogen atoms have been replaced by the fluorine, a colorless, odorless, dense liquid that is the chemically inert and poorly soluble. This should be emulsified with albumin of X for better tolerance. Emulsion of the fluorocarbons is injected alone may cause pulmonary embolism, asphyxia and death. Its half-life varies from 2 to 7 days. Dear students, here is the end of our surgery lecture number 74, that is the blood transfusions and blood substitutes. Thank you.